Hi, and welcome back to Ready, Set, GYO, your on-the-go guide to learning gynecologic oncology. I'm Sydney.
And I'm Maya. This is a podcast for fellows by fellows. We are here to help you explore the diagnosis and treatment of gynecologic cancers, master the standards of care, and stay on top of new practice-changing publications.
Let's get ready to GYO!
This is the 5th episode in our ovarian cancer series. Today, we are going to be discussing the less common epithelial ovarian cancers. We'll discuss sex cord stromal tumors and malignant germ cell tumors in the next episode. Sydney, what are our learning objectives for today?
Our learning objectives are to understand the usual standard of care for less common ovarian cancers is full staging. However, fertility-sparing surgery can be considered for early stage and low-risk tumors. Acknowledge that low-grade serous ovarian carcinomas are less sensitive to typical ovarian cancer chemotherapy regimens than high-grade serous ovarian carcinomas. However, they do have some unique therapy indications. Recognize that mucinous tumors have disparate outcomes in regard to stage, and identify how the management of borderline neoplasms of the ovary differ from the management of early-stage malignant neoplasms.
So, Sydney, this episode is about the less common types of epithelial ovarian cancer. How common are these cancers, and which are more or less common?
If you recall, we discussed in our early epithelial ovarian cancer episodes that epithelial ovarian cancers make up 95% of primary ovarian malignancies. Among those epithelial cancers, 70 to 75% are high-grade serous cancers. The remaining 15 to 20% include carcinosarcomas, clear cell carcinomas, mucinous carcinomas, low-grade serous carcinomas, and endometrioid carcinomas. Maya, if we have an epithelial ovarian cancer of one of these less common types, is the workup different than high-grade serous ovarian carcinomas?
Great question. All of the less common ovarian cancers use the same staging system as for high-grade serous cancers. The workup is generally similar for these tumors, although many of the less common ovarian cancers are diagnosed postoperatively. Head back to Ovary Part 1 to review what to do in that scenario. So, full staging for these tumors includes a total hysterectomy, bilateral salpingo-oophorectomy, omentectomy, pelvic and para-aortic lymphadenectomy, and an appendectomy if abnormal appearing, in the case of mucinous tumors. In our first ovarian episode, we also discussed fertility-sparing surgery, which can be considered for patients with apparent early-stage disease, so clinical stage 1 disease, epithelial tumors, and/or low-risk tumors, which include borderline tumors. Clear cell cancer has a poorer prognosis than other subtypes, and there's debate about the appropriateness of fertility-sparing surgery in this population. There's some retrospective evidence that in stage 1 clear cell, fertility-sparing surgery is safe compared to more aggressive surgery. Unfortunately, due to poor prognosis for patients with ovarian carcinosarcoma, also known as malignant mixed Mullerian tumor, fertility-sparing surgery is not recommended in this population, regardless of stage. In the preoperative workup, tumor markers such as CA19-9 and CEA can be particularly helpful to detect an occult GI malignancy or to differentiate the primary source of a mucinous tumor. In our next episode, we'll talk specifics of tumor markers for germ cell and sex cord stromal tumors. Remember that for all ovarian cancers, tumor sequencing can be very helpful to identify targeted therapies or clinical trials. Once we complete our surgical evaluation, how does management differ for the different subtypes of the less common epithelial ovarian cancers?
Let's walk through this type by type. We'll start with low-grade serous ovarian carcinoma. Low-grade serous carcinoma accounts for less than 5% of all epithelial ovarian cancers. Diagnosis is made pathologically by the degree of nuclear atypia and mitoses, being mild to moderate nuclear atypia and less than 12 mitoses per high-powered field. About 60% of low-grade serous carcinomas are associated with a serous borderline tumor at diagnosis. These cancers generally present at a younger age than high-grade serous ovarian carcinoma, and about 90% are stage 2 to 4 at diagnosis. Characteristic mutations are in the MAP kinase pathway, most commonly with KRAS or BRAF mutations, versus p53 mutations commonly seen in high-grade serous ovarian carcinoma. Because they're slow growing and have less mitotic activity than high-grade serous ovarian carcinoma, they're less chemoresponsive. Since low-grade serous cancers aren't as chemoresponsive, if diagnosed preoperatively, typically neoadjuvant chemotherapy is not the treatment of choice, and primary debulking surgery is preferred. After our patients with low-grade serous ovarian cancer undergo surgery, which patients will require adjuvant therapy?
Because low-grade serous cancers are less chemoresponsive than high-grade serous tumors, adjuvant therapy recommendations are different than for high-grade serous tumors. Stage 1 low-grade serous carcinoma is very rare, accounting for only 2 to 6% of all low-grade serous tumors. Thus, prospective data for adjuvant treatment doesn't exist. However, for patients with stage 1A and 1B disease, observation is recommended. There's no widely accepted approach for 1C disease. For those that have stage 2 and above disease, systemic therapy is recommended. Preferred regimens include carbotaxol plus minus bevacizumab or hormonal therapy. Retrospective data has suggested benefit to using bevacizumab in patients with low-grade serous cancers, but we have poor prospective data for Bev in this group. Patients with low-grade serous cancers were included in ICON 7 and did not derive a survival benefit in long-term outcome analysis. Hormone therapy with aromatase inhibitors alone is also listed as a 2B preferred option in the NCCN guidelines. A prospective study, NRG-GY019, evaluating carbotaxol and maintenance letrozole versus letrozole monotherapy is ongoing. So after primary treatment is completed, are there options for maintenance therapy like there are in high-grade serous ovarian cancer?
Great question. Greater than 90% of low-grade serous ovarian cancers are ER-positive, and hormonal maintenance therapy can be considered after adjuvant chemotherapy. In a retrospective study by Gershenson et al. In 2017, patients treated with maintenance hormonal therapy after primary surgery and adjuvant platinum-based therapy had a progression-free survival of 65 months versus 26 months in the observation following surgery/platinum-based chemo group. The majority of patients in this group received letrozole and about 1/3 received tamoxifen. Maya, what about treatment for recurrent or persistent disease?
Patients with recurrent disease can be considered for secondary cytoreduction. Systemic therapy treatment options for recurrent low-grade serous ovarian cancer include several targeted therapies or the same systemic chemotherapies as discussed for high-grade serous ovarian carcinoma. The Milo ENGOT OV 11 study was published in 2020. This was a phase 3 trial of 303 patients that were randomized 2-to-1 to binimetinib versus physician's choice chemotherapy in recurrent low-grade serous ovarian cancer. Binimetinib is a MEK1/2 inhibitor, which targets the RAS/RAF/MEK pathway. Patients were allowed up to 3 prior lines of chemo and could have had prior hormonal therapy. The primary endpoint was PFS. This study demonstrated no difference in PFS, overall response rate, or overall survival in the intention to treat population. However, in an exploratory analysis of patients with tumors that had a KRAS mutation, the PFS was 17.7 months versus 10.8 months in those treated with binimetinib versus not. There was no difference in response to chemotherapy. The most common greater than grade 3 toxicity was increased blood creatinine kinase level. The takeaway from this trial was that KRAS could be a predictive biomarker for response to binimetinib. A follow-up analysis of this study, published in 2023, evaluated the impact of treatment with binimetinib based on other mutations in the KRAS pathway. PFS was significantly longer in patients with mutations along the MAP kinase and KRAS pathway, with a hazard ratio of 0.5. Are there other targeted therapies available for low-grade serous ovarian cancer?
The use of trametinib in recurrent low-grade serous ovarian cancer was evaluated in GOG 281, published in 2022. This study included 260 patients randomized 1-to-1 between standard of care chemotherapy or trametinib. Standard of care therapy included Taxol, Doxil, topotecan, letrozole, or tamoxifen at investigator's choice. Progression-free survival with trametinib was 13 months versus 7.2 months in the chemotherapy group, for a reduced risk of disease progression or death of 52%. There was a high crossover rate from the standard of care chemotherapy group of 68% to the trametinib group. Patients with KRAS, BRAF, NRAS mutations had a more robust response than those with wild-type tumors. However, the benefit persisted in the intention to treat population. Okay, Maya, question. If these drugs were both MEK inhibitors, why do we think trametinib showed a more robust response?
So we can't compare across trials directly, so it's hard to know exactly. There's some preclinical data that trametinib may be a more potent MEK inhibitor. There were also differences between these two studies in the number of prior treatment lines and the standard of care options that were given. Lastly, the control group in the Milo study also had a better than expected PFS, suggesting a possibly better prognostic group in that study. Taken together, these two studies were a very huge accomplishment in the treatment in low-grade serous ovarian cancer. There were no new advances for decades in this disease type, and these trials opened up options for patient treatment when surgery is no longer an option. I think I heard about a study that combined trametinib with another agent. Sydney, do you recall what that was?
Yes. The NCI MATCH study had a sub-protocol which evaluated dabrafenib, a BRAF inhibitor with high affinity for BRAF V600E, with trametinib in patients with tumors that had BRAF V600E mutations. This included 5 patients with low-grade serous ovarian carcinoma and 1 patient with mucinous peritoneal primary cancer. The overall response rate in the whole study was 38%, with a PFS of 11.4 months. In those with gynecologic cancers, 5 out of the 6 had a partial response, with 3 patients having a greater than or equal to 12 months duration of response, and 1 patient having stable disease for 8 months after treatment. Based on the results of the above studies, trametinib alone has a 2A recommendation for recurrent low-grade serous ovarian carcinoma. Trametinib plus dabrafenib has a 2A recommendation for those with a BRAF V600E mutation, and binimetinib has a category 2B recommendation.
Is there anything else on the horizon?
Also, yes, there's an ongoing trial called GOG 3097 ENGOT OV81 NCRI RAMP 301, which is a phase 3 randomized open-label study of combination therapy with avutometinib plus defactinib versus investigators' choice of treatment in patients with recurrent low-grade serous ovarian cancer. We look forward to seeing the results of this study. Maya, any other things to consider when treating recurrent low-grade serous ovarian carcinoma?
Like we mentioned, hormonal therapy is another category 2A option. An aromatase inhibitor is preferred if the patient didn't get an AI during their upfront treatment. If they did, then a hormonal agent with a different mechanism of action, like fulvestrant, Lupron, or goserelin, should be chosen. The Alepro trial is an ongoing study evaluating abemaciclib and letrozole in ER-positive rare ovarian cancer. If you remember from our advanced uterine cancer episode, this regimen was recently published as a phase 2 trial in advanced EC. We look forward to the results of that trial. Sydney, we mentioned precursor lesions to low-grade serous ovarian cancer as borderline tumors. Can you tell us more about that?
Absolutely. So about 60% of low-grade serous cancers will be associated with serous borderline tumors, which were previously called low malignant potential tumors. Borderline tumors can also be of mucinous histology. True borderline tumors are not technically cancer, as they don't invade the basement membrane. These true borderline tumors account for about 15% of all non-benign epithelial ovarian tumors, and most are either serous or mucinous. They can be bilateral in up to 50% of cases. Prognosis from borderline tumors is very good, with a 5-year survival of greater than 80%. Patients are younger and disease is often stage 1 at time of diagnosis. Because of this good prognosis, fertility-sparing surgery is an option. Maya, borderline tumors by nature aren't invasive, but can they invade?
Yes, and this is kind of confusing. The definitions and terminology surrounding borderline tumors are a little tricky and have changed over time and are still slightly controversial. Some borderline tumors can have ovarian microinvasion. This is defined as less than 5 millimeter focus of ovarian stromal invasion. These borderline tumors with microinvasion have, in most studies, not been associated with an increased risk of recurrence And so they're not treated as overt cancer if the invasive implants are confined to the ovary and are microinvasive. Borderline tumors are on a spectrum with low-grade serous cancers, and there's debate about the management and prognosis of tumors with microinvasive implants outside of the ovary. Advanced stage ovarian serous borderline tumors with invasive implants have about a 30% risk of recurring with invasive disease after primary surgery. The NCCN and ESGO both recommend treating borderline tumors with invasive implants as borderline tumors and not invasive low-grade serous ovarian cancer. However, the WHO classifies this disease as metastatic low-grade serous carcinoma. Advanced stage borderline tumors with non-invasive implants also have a risk of recurring with either borderline or low-grade serous ovarian cancer. And some studies show up to a 30% risk of recurrence with low-grade serous ovarian cancer for an original non-invasive borderline disease. These recurrences can occur years after the initial treatment, even up to a decade after, and so surveillance after treatment of borderline tumors is necessary. Are there any other features that can change the prognosis of borderline tumors?
I'm glad you asked. Yes, having micropapillary features on pathologic examination increases the risk of having invasive peritoneal implants and increases the risk of recurrence. How do we treat borderline tumors?
Borderline tumors are treated surgically. As mentioned, they can be treated with fertility-sparing surgery if desired by the patient. Lymphadenectomy is not typically performed in the surgical management of borderline tumors. Although lymphadenectomy does sometimes upstage the borderline tumors, it has not been shown to improve outcomes and doesn't change treatment decisions, so the surgical risk outweighs the benefit. Omentectomy should be performed and multiple peritoneal biopsies should be done to make sure an occult low-grade serous ovarian cancer isn't present and to completely stage the patient. If after a full pathologic evaluation, there's no low-grade serous ovarian cancer identified, then observation is the preferred postoperative strategy. Sydney, now that we've talked about borderline tumors, which can include mucinous borderline, can you tell us about mucinous ovarian cancer?
Sure thing. The first thing to do is to make sure that it's actually mucinous ovarian cancer and not mucinous cancer from a different primary site. Primary mucinous ovarian cancer is really rare, accounting for only 3% of all epithelial ovarian cancers. A metastatic cancer to the ovaries is more likely than a primary ovarian mucinous tumor. Tumor markers like CA19-9 and CEA can be informative. If they are elevated or imaging is suggestive of a mucinous tumor, it's important to do a GI evaluation, which can include upper and lower endoscopic evaluation. Some immunostaining can also help distinguish between primary sites. While ovarian tumors often express PAX8, cancers of colonic origin are more likely to express SATB2, CK20, and CEA. Ovarian mucinous cancers occur in younger patients, often are early stage, and have good prognosis if diagnosed at an early stage. 5-year disease-free survival is 80 to 90%. They often have KRAS mutations, P53 mutations, and some also express HER2. They don't tend to be associated with BRCA mutations. Maya, is there anything we do differently for mucinous cancers of the ovary?
So many providers will perform an appendectomy. Per the NCCN, this is only required if the appendix appears abnormal and can be omitted if the appendix appears normal. The surgical approach can also incorporate the pattern of invasion if it's known prior to surgery. Tumors that have an infiltrative subtype present more frequently with advanced disease and are more aggressive. Expansile subtypes are less aggressive. A lymphadenectomy can be omitted if there are no clinically enlarged lymph nodes and mucinous histology is confirmed intraoperatively. In retrospective studies, lymphadenectomy does not improve recurrence rate, progression-free survival, or overall survival in clinically stage 1 mucinous ovarian cancer. Some providers do perform lymphadenectomy for infiltrative subtypes of mucinous cancers due to their aggressive nature. The NCCN does not include subtype of disease in their treatment recommendations, but other organizations like ESMO do include subtype. ESMO recommends adjuvant chemotherapy for all infiltrative subtypes, while the NCCN recommends observation for stage 1A and 1B disease of either subtype. So we said that most people are diagnosed at an early stage. How do people fare if they're diagnosed with advanced stage disease?
Primary mucinous ovarian carcinomas that are advanced at the time of presentation unfortunately have a very poor prognosis. In one study by Winter et al., PFS after surgery and adjuvant chemo for advanced mucinous tumors was 10.5 months versus 14.8 months in other histologies, and overall survival was 16.9 months versus 49.2 months. For patients with stage 2 to 4 disease, systemic therapy is required, and adjuvant therapy can be considered for stage 1C disease. Chemotherapeutic options include carbotaxol, 5-FU, leucovorin, and oxaliplatin, FOLFOX, which is a GI chemotherapeutic regimen, or capecitabine and oxaliplatin, CAPOX, a GI regimen. There is extremely limited data to guide the choice of chemotherapy. There's really only one study, GOG 241, which attempted to randomize patients with primary mucinous ovarian carcinoma to different chemotherapeutic regimens. The study only enrolled 50 patients and was closed early due to low accrual and poor pathologic review. Almost half of the patients were reclassified as mucinous ovarian carcinoma metastatic to the ovary. They compared carbotaxol plus minus Bev to capecitabine oxaliplatin, CAPOX, but again, we don't have the results of this trial. A retrospective study published by Kernet et al. In 2019 compared the use of GI versus GYN regimens. They identified 52 patients, with half being treated with each arm. More patients in the GI regimen of this study got bevacizumab. Both PFS and OS favored the GI regimens. As such, these GI regimens are both preferred regimens, as well as carbotaxol, all with the option to consider bevacizumab. Generally, CAPOX is a better tolerated regimen than FOLFOX, and they otherwise have similar oncologic outcomes. Adding bevacizumab does increase the toxicity of these regimens, and GI symptoms can be dose-limiting. As with our other tumors discussed today, molecular tumor testing and consideration of targeted agents is important, especially in the recurrent setting. Maya, can you tell us about endometrioid carcinoma of the ovary?
My pleasure. Endometrioid ovarian carcinomas account for about 10% of all ovarian cancers. They're often diagnosed at an early stage, and they tend to respond well to chemotherapy. Histologically, these tumors represent low-grade endometrial carcinoma, and sometimes it can be difficult to distinguish where the primary disease is, as 15 to 20% of the time there will be a concurrent uterine endometrioid carcinoma. Certain pathologic features can help point the pathologist towards an ovarian primary, like minimal myometrial invasion, a unilateral ovarian mass, a lack of ovarian surface involvement, a large ovarian mass with expansile growth pattern, among some other findings. These cancers are associated with and believed to often arise from endometriosis. Mutations in the PTEN and CTNNB1 genes are common, and they usually are ER positive. Stage 1A and 1B disease can be observed if completely resected, but chemotherapy is typically recommended for stage 1C disease and above. Chemotherapeutic choices have the same algorithm as low-grade serous ovarian cancer, including carbotaxol with possible bevacizumab. As with low-grade serous, maintenance letrozole can be considered for endometrioid tumors, but this is a category 2B recommendation. Hormonal therapy alone as primary adjuvant therapy is also a category 2B recommendation. We're getting close to the end. Sydney, what are some pearls about clear cell ovarian carcinoma?
Clear cell carcinoma of the ovary is a high-grade subtype of epithelial ovarian cancer. While in the US, these account for a very small fraction of ovarian cancers, in Japan, they can be up to 25% of cases, and we don't have a good understanding of why this is. The presenting picture of clear cell ovarian cancers can sometimes be unique. They are associated with thrombosis and hypercalcemia, so keep an eye out for these features in patients presenting for initial evaluation. Clear cell cancers, like endometrioid cancers of the ovary, are associated with endometriosis. Fun fact, tubal ligation has been found to be protective, potentially from tubal occlusion, preventing retrograde menstruation. For clear cell carcinomas, fertility-sparing surgery is not recommended due to high-grade disease. If diagnosed at an early stage, they have relatively good prognosis, but in advanced stage disease, prognosis is worse than high-grade serous ovarian carcinoma or endometrioid. Adjuvant therapy is recommended for all stages with IV carboplatin and paclitaxel plus minus bevacizumab, despite these tumors being more likely to be platinum resistant. Maya, can you tell us about our final subtype of less common ovarian cancers?
We're sort of saving the worst for last here with the discussion of carcinosarcoma, also known as malignant mixed Mullerian tumor of the ovary. These are the most aggressive ovarian neoplasms, and they're thought to be a variant of poorly differentiated epithelial ovarian cancer with a sarcomatous component arising from an epithelial precursor. They tend to be present at an older age with a mean age of diagnosis of 75. Because of their aggressive nature, fertility-sparing surgery, if applicable, is not an option, and all require adjuvant chemo. Adjuvant chemotherapy choices are the same as for other epithelial ovarian cancers. Cisplatin ifosfamide, carboplatin ifosfamide, and ifosfamide Taxol are also category 2A options. Recall that in uterine carcinosarcoma, ifosfamide was historically the preferred agent before carbotaxol. Germline and somatic BRCA testing should be done, and PARP inhibitor maintenance can be considered for patients with BRCA mutations. Surveillance and recurrence therapy are all the same as for other epithelial ovarian cancers. All right, that's all we got for you today. Let's recap what we learned. High-grade serous ovarian cancer is responsible for about 70% of ovarian cancer. The remainder of epithelial cancers include low-grade serous ovarian carcinoma, mucinous carcinoma, clear cell carcinoma, endometrioid carcinoma, and carcinosarcoma. Sex cord stromal tumors and germ cell tumors will be covered in the following episode.
Fertility-sparing surgery can be considered for patients with early-stage and low-risk tumors. Low-risk tumors include malignant germ cell tumors, borderline epithelial tumors, some clinical stage 1 epithelial ovarian tumors, clinical stage 1 mucinous tumors, and clinical stage 1 sex cord stromal tumors. Those with clear cell or carcinosarcoma of any stage should undergo full comprehensive surgical staging.
Low-grade serous ovarian carcinoma are typically less chemoresponsive than high-grade serous. Neoadjuvant chemotherapy is generally less favored. Most low-grade serous ovarian carcinomas are ER positive, and hormonal therapy is an option to add to treatment. Alterations affecting the MAP kinase pathway are present in 30 to 60% of low-grade serous ovarian cancers. Thus, it harbors a unique, targetable pathway that can be targeted with therapies such as trametinib, binimetinib, and dabrafenib.
Borderline tumors are non-invasive, but can have microinvasive implants on the ovary or elsewhere in the abdomen. If the final diagnosis is borderline, even in the presence of microinvasion, most gynecologic oncologists recommend conservative therapy via surgical excision without adjuvant therapy, especially in patients who are desirous of further childbearing and have stage 1A disease. Chemotherapy should be reserved for patients who develop pathology consistent with invasive disease.
Mucinous tumors in the ovary are usually from a different non-ovarian primary. So if you find one, it's crucial to rule out metastatic disease. The majority of mucinous tumors are discovered at an early stage, and the 5-year disease-free survival is 80 to 90%. However, if they're diagnosed at an advanced stage, their prognosis is worse than that of serous, endometrioid, and clear cell cancers. Infiltrative subtypes are more aggressive than expansile subtypes on average. Chemotherapy for mucinous tumors often uses a GI-type regimen such as Capox or Folfox.
Endometrioid and clear cell carcinomas of the ovary are associated with endometriosis. While endometrioid are less aggressive and can be observed after surgery in early stages, clear cell cancers are more aggressive and adjuvant therapy can be considered in all stages. Carcinosarcoma, our last and most aggressive subtype, has a poor prognosis, and treatment options are the same as high-grade serous ovarian carcinoma.
This has been another episode of Ready, Set, GYO, your source for all things gyno.
If you'd like to check out today's show notes, take some practice questions, or explore resources we use to create the podcast, head to readysetgyo.com, the companion website for our podcast. We encourage you to reach out if you have ideas for new episodes, questions or comments about existing episodes, or thoughts of how we can make this podcast even better suited for you. We're excited to continue to learn with you.
To stay up to date on all things Ready Set GYO, check out our Instagram and Twitter at Ready Set GYO.
To support us and our production of future episodes, check out our Patreon at Ready Set GYO.
This episode was recorded by Sydney Oesch and Maya Gross.
Our sound editor is Brogan Brown.
Our media and website manager is Sky Jacobson.
We'd like to thank Dr. Brian Orr, faculty at the Medical University of South Carolina, who reviewed the content of this episode for accuracy and completeness. Sydney and Maya signing off.